Hi, this is Dr. Sherry Shabowski from Medical Education in Minutes. This video is from the Classic Clinical Presentation Series, and today we are going to meet Ina Farcto. Meet Ina Farcto, a 68-year-old female smoker with a past medical history of chronic renal insufficiency, hypertension, and high cholesterol. Today she woke up feeling a bit off and vaguely nauseated. Then she started to get a dull ache in her left shoulder. She went to the bathroom and she noticed the shoulder pain was getting worse by the second. She tried rubbing and rolling her shoulder, but it didn't get better. She braced herself on the sink. Her shoulder pain was getting intense. She started feeling weak and short of breath. Then she broke out in a cold sweat. She was really scared. So she called 911 and an ambulance rushed her to the hospital. The doctor said, "I'm sorry, Ina, but it looks like you are having a heart attack. I will give you some morphine and we will take good care of you." How did the doctor know she was having a heart attack? Well, the symptoms and the EKG led to that conclusion. Let's take a look at how the depolarization and repolarization of the heart muscle is seen on EKG. First, let's start with the conduction system. It starts at the sinoatrial node, causing depolarization of the atrium. It then passes to the AV node, then to the bundle of His, and then through the right bundle branch and the left bundle branch, which depolarize the right and left ventricles. When you look at the EKG lead, you see a P wave. The P wave is associated with the depolarization of the atria. The PR interval, which is typically a flat line, is caused by the delay as the impulses move through the AV node. The QRS represents the depolarization of the ventricles. The ST segment, which is going to be really important here, is usually isoelectric or a flat line. It is the time between the depolarization and the repolarization of the myocardium. The T wave represents the repolarization of the ventricles. Now let's go through the dynamic changes of an ST elevation MI in evolution. It starts with hyperacute T waves. The next thing you'll see over time is you'll start to see ST elevation. If you see that little tombstone that I put under the ST segment, they call that tombstoning when the ST elevation looks that large. The next thing you'll see is the biphasic T wave, or ST elevation and T wave inversion together. The next thing you might see is a Q wave. Q waves are not uncommon on EKGs, but pathologic Q waves are. They're usually at least 0.04 or 1 small box wide and 2 millimeters deep, or 2 small boxes deep. Q waves represent a loss of viable heart muscle that is no longer generating electrical activity. This is a depiction of the heart and the major coronary arteries that are located in the epicardial space. Branches of the coronary arteries dive down into the myocardium to supply oxygen to all the tissue. A heart attack occurs typically from a coronary artery with atherosclerotic disease. the atherosclerotic plaque ruptures, seemingly sometimes for no reason. And that causes a clot to form, which results in complete obstruction of the vessel. No blood moves past the obstruction, and therefore the downstream myocardium is starved of oxygen-rich blood. Ischemic tissue is the tissue that is starved of oxygen-rich blood, and this causes pain. The myocardium feels like he's being crushed, maybe like an elephant is sitting on the chest, perhaps. When the tissue dies, the pain stops. This is an infarction. That piece can no longer contract. In fact, it scars. And if you look at it with an ultrasound or an echocardiogram, you'll notice on the test that that piece is non-mobile, showing you that that is where the damage occurred. The ischemia transitions to infarction very quickly. So from the initiation of pain to the death of the tissue, it's about an hour. So you must act quickly. Treatment is twofold. First, you want to stop the clot formation so it doesn't keep getting bigger and bigger. This can be done with drugs like aspirin or sometimes clopidogrel. Sometimes both are used. Then you need to remove the obstruction. This can be a physical removal of the clot or giving medication that breaks down the clot. These medications are sometimes called clot busters. Let's talk a little bit about aspirin. The chewable aspirin is best. Remember, we said it's really important that things go quickly, right? The clot is forming. It starts as soon as the pain starts. So you might want to give the patient chewable aspirin because it has faster bioavailability. They can also chew normal aspirin, but it tastes pretty bad. The aspirin irreversibly blocks cyclooxygenase 1 enzyme in platelets, which prevents the production of thromboxane A2. Thromboxane A2 plays a role in the platelets sticking together and forming that clot. So if you can give the aspirin really early, that could stop the clot from growing even bigger. Clotting has to be balanced. Where clots formed, they must be removed. Plasmin breaks down the fibrin mesh and therefore breaks down the clot. TPA is tissue plasminogen activator, which causes the production of a lot of plasmin. This causes clots to be broken down much faster. Kind of like Drano for a blood vessel. The risk factors for myocardial infarction include, as always, the HIB-HIA primarily. That is, had it before, had it again. If you had one heart attack, you know you're predisposed to potentially having another. A strong family history can play a huge role, especially if someone tells you something like, my parents and my siblings all had heart attacks by the time they were my age. That should really raise the hairs on the back of your neck. If the patient is a proven vasculopath, that means they're known to have vascular disease. So if they've had renal failure, or they've had a stroke, or they have peripheral artery disease, they are at high risk for coronary artery disease and therefore a heart attack. Now, the following are risk factors for sure, but not quite as strong as the other side. They include older age, smoking, metabolic syndrome, which includes diabetes, hypertension, high cholesterol, and obesity, a sedentary lifestyle. And sadly, for the people who use cocaine, cocaine actually accelerates coronary artery disease. So definitely should not be used in excess, if at all. Ina is now in cardiac rehab and doing really well. Thank you, doctor. If you like this content, please like and subscribe to my YouTube channel. And check out www.medicaleducationinminutes.com for more. I'll see you next time, and in the meanwhile, keep studying.